Thank you. Good morning, everyone. I have a cold, so I'm going to apologize for that ahead of time. I am thrilled to be here. I am actually just totally thrilled that this conference is here and that you're doing what you're doing. So I'm going to tell you a little bit about the way I think about the world. So I'm in a Department of Computer and Information Science. So I spend my day with all sorts of people that create algorithms, create tools, create things often to do whatever they think it should. I want them to help you do what you know it should do. Everybody that knows me knows this is really important to me. We're talking about mental health, but you know what? We have a problem. Our healthcare system, despite everybody working really hard, is failing. So this is the OECD countries from 2015. You can see we're doing poorly. You can see it whether it's men, and if you look at the causes, you can see all of the causes that we often talk about are not the only ones contributing, and mental health's in there. Here's women, same issues. You all know, this is your world, the prevalence for mental health issues, whether it's, I don't know how the CDC had actually defined it here, but I think we all know it's underestimated, that the problem is more, that the rates are really high, but the numbers are really worse than we know. Here's one from NAMI about mental health in the workplace. So I think no matter how you think about it, this is a cost to to humans, to society, to everything. And it's something that I always talk about every time I start, because in computing, that's not the thing we often think about first. So I try to get people to realize this is a crisis and we need help. I think the thing, though, that I think about when I look at is things like this. These are barriers. And what I really think about, I think we've heard them before. I think some of these barriers really can be overcome with technology in ways we haven't thought of before. And I guess what I'm going to talk to you about today is, how do you partner with people that are not like you? And it doesn't just mean industry. How do you partner with people who have completely different skills, completely different language, completely different, they don't even get paid in the same way you do, yes, hard, an academic salary for 9 months, guaranteed. This is not the same world that we're living in, but I think it's really important to think about this. So what do we do? I think we've talked about data. Data is changing so rapidly. And if you sit in the world of computing, you all think about promise and genes and information from just sensors. I have people that are so much farther into the weeds in terms of thinking about what's coming off of phones, what's coming off of light posts. You don't realize it. We have millions of cameras. There are microphones, there are cameras. There is Alexa in your house or Google Home or whatever you want that's collecting oodles of data about you. But this data could be used for good. We have mobile sensing data. Now you talk about it, I think it's unusual almost to see people without a watch on, and it's always, now the smartwatches are becoming to look like regular watches, but they're there. And I think that this is not an age thing. I think we're seeing this across. I think the last panel, one of the things where people are not against adopting technology if it works. We have smart shoes now. I believe the smart contact lens is dead, but I think there'll be more coming. But we have mini, teeny, micro, 1 millimeter by 1 millimeter chips being developed that will last forever. Turns out it's more expensive to get a chip out than in, so you have to make them last. We also have patient-shared data, and there are many, many repositories for this that are growing all the time. The MVP is the Million Vets program. I believe they have over 700,000 vets enrolled now. LPHI, Louisiana Public Health Initiative, which is bringing together EHR, public health information, emergency services, and criminal data to try to figure out what they need to do and how they can help. Vivly is for clinical trial data. FDA Sentinel, many of you may know, All of Us is the NIH initiative for 1 million people. But I think the thing to think about is, no matter how we think about whatever we recruit, technology is growing by the hour. This is from Eric Tobel from 2015. I'm sure Eric's come up with something new on this. But right now, and actually for quite a while, there are more phones than toilets. You know, there are more phones than toothbrushes in this world. So we have sensors around things that you would never even understand. Many people, like you can now order your little Amazon button so you can get new Dash products, new whatever. I'm not endorsing anything, by the way. But you can push the little button and it reorders. But it also tells you where you are at that button. All sorts of data come through that. Thinking about where these sensors are and how do we do it more than just selling products? I think there's the interest is that you all wouldn't be sitting here if you just wanted to use these things to get something done. You want to make a difference. You want to make a change. We also have advanced analytics. Many of you saw Google solved one of the major problems in what, 1/100th, I don't know, 1/100,000th of a time that it would have taken. So when I hear questions of analytics, everybody's on quantum computing now. I have people that are doing analytics that you can't even imagine. You know, they take big data. There are now teams devoted to taking data from diverse sensors and piling it in and figuring out how to analyze it without harmonizing it, without a whole lot of information. We can do these things if we work together. I think the other thing is what you don't realize is there's all sorts of things that are being used as sensors too. Vibrations in the floor. You don't realize it, but all the buildings built now, this one probably, have sensors in the floor that are looking for earthquakes, whatever, looking for structural problems. But do you realize you can do gait with that? You can tell how somebody's moving. People are really starting to figure out now, can you tell differences in gait over time? What a nice, unobtrusive way to think about the world. Light. People are using light to communicate now. So let's not put a signal. Let's let light do it. And Wi-Fi. Wi-Fi bounces off of you. So when you have Wi-Fi in a room, you can use it as a sensor. So all of these things, these and more become opportunities. Our digital devices, I don't know if you saw the robotics study recently. They had a little robot, this one, awful cute. And they asked the little robot, they said to the people who were doing it, like 1/3 of them were told, turn the robot off when you're done. Another third were, so they just, and the robot didn't say anything, they turned them off. Another third were told, turn the robot off when you're done. And the robot said, please don't turn me off. I don't want it to be in darkness. All of a sudden it was like 50% turned it off. I mean, it's like 80%, so somebody was non-compliant no matter what. But then they had the robot say, please don't do that. I'm scared of the dark. Don't turn me off. And all of a sudden, it's like down to 20% of people who will turn the robot off. Now, I'm not saying we need to create the next HAL because we need to, but I think what the people are really trying to figure out is how do you program robots in a way that makes them appealing, that make you want to do things with them. And if you're thinking about it in older cases and things, how do you think about a robot that might improve social isolation, that might be able to collect data, that might be able to provide information? I funded a project last year that's doing cognitive rehabilitation with a robot who talks back to you, who notices changes in your movements and talks to you about things and talks to you about, just see the Nationals lose last night? Assuming that gets a response out of anybody that ever cared about the Nationals. But we have things like Google Home and Alexa that are collecting data but are also able to talk to us. And we have people that are analyzing that data and using that natural language processing in a way that can speak to people in a way they understand. You know, there's studies now being done. How do you talk to somebody in a way that makes sense? Not only the content, but the speed, the prosody, everything. Should you be excited and animated? Should you be flat? People did this years ago when they started with Siri and Garmin voices. You know, it was like, did you want a man telling you where to go? You can see the way this is all played out now that you know all your voices. But tablets have become ubiquitous. We are seeing health centers giving away tablets after surgery because you can do so many things. You can make videos, you can do the imaging, you can use all sorts of information. And if you want to know if older people will use it, I went into a meeting one day, and my phone is going off. I had my phone up here with me, and I was checking the time, and my phone is going off, bing, 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 bing. And I'm thinking, like, stop, you know? I get off the podium, and I look, it's my mother. I've bricked my iPad. That's her email. I have bricked my iPad. Now, first off, I don't know how she knows what bricking is, because that's not a term that I'm pretty sure is in common use, but she had actually locked up her iPad and killed it. And she was crying by the time I called her. I don't know what to do. I can't even go out. It's got my Google Maps in it. So I went through how she could unbrick her iPad, and we got it working, and she's good. And now she's got the watch, so now it's all good. But when technology is useful for people, they use it. And I will say, Dave Gustafson in Wisconsin has done a lot of work with aging populations. And one of the things he found that people didn't want new technologies for nothing. So what they wanted was, so if you teach me how to use it, which teaching was a big part, but can I have Skype? Can I have Facebook? Can I have FaceTime? Because my grandkids are on FaceTime. Right? So think about all of the things. We often want people to do what they want us to do, what we want them to do, Here, do this, take this questionnaire, take an image of this picture, add this data. But what I really want to use it for is talking to my grandkids. If you give them the grandkids, it's amazing how much data people will put in and how frequently they will use things. And there are more devices. There are all sorts of things happening to help people either collect data, these are mostly rehabilitation now, but you can imagine, we've seen virtual reality a lot in PTSD. But what do we need to do to get there? Because I think there's always a gap. I think the first thing I want you to think about is user-centered. Whether it's coming out of the human factors world in engineering or human-computer interaction, there are people that make their living figuring out how to get you to use your device more. So, it's all well and good to get people to click on Google, but wouldn't you rather have them click on a device that's going to help their mental health? That they can use it, that it has information in a way that makes sense? I know a researcher who had this really fabulous mental health. She had 2 awards from NIH. It's back when I was with NIH. She was going to work with young adults with schizophrenia. She built the app. They had an app designer come in. They built it, and guess what? The usage was almost 0. They built the entire app before they tried it, too, which I think in the computing world we would never do. But so she went to she went to a company that really works on user-centered design. And they said, you brought them to Psychiatry to develop this? Oh, let's not do that. Did you do mock-ups? Did you do wireframes with them? What else did you do with them? Well, we just asked them questions, what they wanted. And they said, that's it? So they brought them in. They did all sorts of exercises. They built samples. They brought more people in. They went through again and again. And now they have an app that's functioning, that people are using, that they can really start to figure out, is it going to do what we thought it would do? In the past, they just couldn't get people to use it because it was offering things that people didn't need. I also think that if you're going to compete for attention, which we're always competing for attention, right? How do we want to be? Do we want to be playful? Do we want to be attentive? Do we want to be serious? How do we want to do that? But I think there's a whole lot of data. There are people that stand at conferences and say, if the avatar tilts their head this way, it means this. If it's this way, it means this. These are not things that you would normally know when you're thinking about technology for psychiatry. But they're really critical to designing things people will use. If you want to use an avatar, why? If you want an avatar to do things, how? These are really, really important as you think about them. So think about it. Also, content. How do you personalize content? My husband says he never has to worry about buying me a present anymore or knowing where I am because it always shows up in his Google feed. Google manages to completely personalize his content so that he knows exactly what I'm doing. He somehow doesn't use Google in the same way I do, so I have no idea what his is. But it's funny. He'll say to me, are we looking at a new boat? Because I'm really getting scary things. I did one day just to freak him out. I looked at airplanes for a while. Showed up in his feed instantly, and he said, it's a 1959. You wouldn't do that, would you? But we can think about this, use these tools, use this knowledge for good. It shouldn't just be to sell airplanes. It should be for a whole lot more than that. I think we need to think about just-in-time. We have researchers doing wonderful work on this. But how do we think about just-in-time? How do we think about delivery? How do we think about when people want it delivered? I always love it. My mother and I were sitting in the movie the other night, and her watch says, "It's time to move now." It's not time to move. She has a calendar date in her phone that says, we're going to the movies on Friday night. Therefore, we should have smarter just-in-time interventions. We should know, what's your schedule? We can do that by asking people, when do they want to be pinged? How often do they want to be pinged? But we can also use all sorts of methods, multi-phase optimization to determine what components and when, but reinforcement learning to figure out when it's doing what we think it's doing. And we can really have information develop with needs. And there are models now for evaluating these things. But what we need to think about is, if you're doing it, I often talk to a company called WellDoc, which does diabetes management. And WellDoc has an interesting business model because if it doesn't work, the insurance company doesn't pay. So it's a very interesting model. But what they do, they found is there's people that will immediately use the app. It's an iPad, it's an app, it's all sorts of methods. But will immediately use it and keep using it, and they do better. There's some that start using it, get better, and then drop out, and then come back later. And there's some that are really hard to engage. And he said, why do I need to do the same thing for all three groups? Why don't I really spend my time and money on those hard to engage folks? The ones that are doing well, congratulate them, ping them, do good job, way to go. The ones that are off, when you're ready to come back, we're here. And the ones that aren't doing it, those are the ones you spend your money on. So if you think about how do we use these tools to do timing, to do information, and how to get it where we need it. Contextaware, this is one of my favorite things. You can't take medication if you left it at home. So you can't do things. You need to have the tools. You have to know what the context is. Don't ping them in the middle of the movie. But I often laugh. People will say to me, we need continuous blood pressure. And I say, yes. So I'm on a roller coaster with my son. And my blood pressure is going through the roof. Do I need my app to say, Wendy, we are worried about your blood pressure? Because most of the things in life are stimulating, right? The really good things are stimulating. And would that be the right thing to do? So we really need to know the context. Am I on a roller coaster? Am I in a movie theater? Where am I? What am I doing? What's my context? I also think, and this is critical, I think, with mental health, is communication central. We talk about stigma. We talk about those barriers around stigma. There are so many opportunities to build this into everything we do and to think about monitoring, to think about how do you use games to give information, how do you do interventions in a way that are not in your face but are happening all the time. How do we think about this? How do we provide the information? What do people want to give? What do we need? We might think about things in very different ways. Google has very, very successfully convinced me to give them all the photos I take so they can put them on the timeline of different places. So, I'm like hysterical. The other day I take a picture on a boat and all of a sudden I get it. Do you want to post this to the point, no point? Yes, that's a place. Point, no point. I'm thinking nobody else has ever taken a picture of it, so I guess, yes, sure. But how do we think about those things for us and for using them for good? I think we need to be personalized. I think sensing is changing so much. Think about how you want to use it, whether it's sensing jewelry, which I'm not sure that worked at all, but I think the idea makes sense. We now have rings. We now have all sorts of technology that is doing sensing. Can we make it personalized? Can we make it something somebody wants to wear, wants to have on? Or can we make the little ones like John Rogers has been doing all along with these little teeny Band-Aid-ish or electronic tattoos? There also is a whole new world of smart clothing. So in China, they now have smart sheets in the hospitals, so you can get information without putting a whole bunch of electrodes on people. Rehab, smart sleeves on your elbow that tell you, are you rotating your arm in the correct way? So this is all data. Maybe it doesn't make sense in mental health for all of these things, but how do I think about that? How do I think about what do I really need to know? And how do I convince people to work with on this? I think it also has to be trustworthy, and I work on the Trustworthy AI initiative that we have, and I often hear people saying, oh no, we have to make our algorithms obvious. Well, we have so many friggin' algorithms in our world that nobody knows what they're doing, but we trust them because they're doing what we want. I think about this in Google Maps all the time. It used to be, I remember when I started, and I would plug it in, and then I would decide, no, I know better, and I would do it. Now I figure they know more about what's happening out on the road than I do. It was funny, they told me that my plane was 4 hours late before JetBlue did. So I think that's pretty funny. But so there's algorithms happening all along, but they have to be trustworthy. They have to have methods. So when we're doing these data analytics, we don't necessarily have to have things coming from the same sources, the same rules, the same information. We funded a project that looks at depression in college students, and they're really doing a scan of the Wi-Fi. The students have all agreed to it, but they're looking at Wi-Fi usage, and they're looking at light usage and when the doors open and close. So the university has all that information. And it turns out they can really well identify who's struggling with depressive symptoms. And what they're doing is trying to triage people, screen students that are struggling early on, and get them help. It's not a perfect screen, but if you think about how little that's costing to do that, you're getting a screen out of it. So dealing with our biases is a huge thing. I think we've always had them. I remember, way back when I used to teach students, and I'd say, remember, you only have the data that you have. And if somebody looks great after a therapy session and you never see them again, it doesn't mean that you did it right. Because all of the data you have is that you never saw them again. It may be they were great, it may be that they're now dead, it may be that they went to somebody else because they hated you. We don't have the right data. We have to keep collecting. So we have to deal with biases. I just read a really funny article, and it was saying, if you want to predict, if you're going to use data to predict who would be a great CEO for a Fortune 500 company, do you know what your analyses show? Should be an older white male. Not saying that older white males don't make great CEOs, but the problem is that's what the data says. That's what the data's always been. So it doesn't tell you if there's a new option and that maybe you missed a large chunk of your potential workforce for a CEO. So we have to think about these biases. We have to think who comes in and who doesn't come in. Who did we see and who did we not see? We have to think about signal and noise. And I will tell you, since I came into the computing world, I used to think, I ran all my analytics and said, oop, look, it's noise. Noise, 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 noise. We say it all the time. It turns out there's signals in noise that we just don't know that they're a signal. So we have to start to think about this in ways that'll make sense. I think we also have to think about a cause and effect. I have a world which just loves to do data and then say it's causal, and I go, no, not really. We really need to be able to work together to get to the world where the data can drive us one way and then we can test it and evaluate it. So we look at this in the simulation world. Generally in the simulation world, they look for the data to put in the model, they test the model, it's very accurate, very good. Now, the data mining people just throw all the data in and say, what do we get? But that doesn't tell you that you have the right relationship. Then you have to go back and test it and create the model and then do the real evaluation. But things also have to be safe. I don't know if you all saw it, but in 2018, CMS, along with many of the other federal agencies, did a report with industry on privacy and security in healthcare. It was pathetic. It was so sad and so sorry. I'm actually having to skip out a little for this afternoon because we're having our safe and trustworthy computing meeting, which is kind of one of the flagship programs in the government on safe and trustworthy computing. They don't think health is a problem. They don't know what the problem is. I'm going to tell them it is a problem and we need you. We need people to quit thinking about individual devices, think about systems, think about data, think about all of these questions, because we can't afford to have these hacks. I think it comes down to evidence-based too. I come from a world where often people are saying, well, it makes sense, it should work. But I always push back and say, would you let your mother do that? It's kind of amazing how fast people can backtrack when it's their mom. If you wouldn't let your mom do it, then it makes sense that you probably aren't quite ready for disseminating things and thinking about them. But we also need new methods. People are developing new ways to evaluate these things in fast-changing environments, both in technology and also in adaptive systems. We're coming up with new models on how to evaluate. I think the representative thing is one of the biggest things that actually drew me into technology. Oops, always does that. It drives me nuts. Larry Green did a study once that said, 1,000 people, you look at 1,000 people in the community and then you say, how many get sick in a given month? That's annoying. How many get sick in a given month? And so, it's something like 200, 250. How many then go to see a primary care doctor? How many then end up in the hospital? How many end up in an academic medical center? How many do you think it is? Out of 1,000, how many end up in an academic medical center? 50? Go lower. 3. 3. It's actually 1. And that was just his study, so I don't know if it's the end-all, be-all. But I think the point is, that's telling us we're not capturing the whole population, and technology allows us to capture a whole population. We can go where people are, and we can actually do it. Actually, I will say that NIH and NSF actually joined together on an effort in digital clinical trials to try to bring technology to the clinical trial enterprise and to really revamp it with the idea that that would allow us to get a whole different group of people. Scalable is one of the big things that I think about. I listen to everything. I'm so excited you're all here because I think this is how we get to scalability. But I also think in health, what we've done is incremental. We keep working. We do one change and another and another. What are the fundamental principles that we really need to know? And then how do we build tools that adapt? So think about your iPhone. When you first get your iPhone, what does it do? What's it say on the screen? Welcome. What else does it say? Language. There's about 20 different languages, right? This is the model of fundamental principles with personalization. You have a model for a phone. Every one of you has personalized your phones to the way you want it, whatever devices that you're using, but the fundamental principles are what drive how do we develop that. How do we think about that for individuals? How do we bring that to mental health? How do we bring that, instead of saying, oh, what do we need to know for an older age group versus a younger age group? What are the points we need to do? This is a very different way of looking at things, but it really is the way we have to start to think. So this kind of gets to what I'm saying, but I think we need to work together on these things. We really need to think about future-proofing. We need to come and think about how do we set up these systems that they're going to change. Phones are not the only way we're going to talk about. My son has consistently, year after year, said, when are they chipping my phone in my arm? We could do it now. We just don't. If you look at some of the countries in Europe, they're using RFID tags and you're scanned to open doors. Like, no more stupid cards. You can just use your hand to open things. We're in a very different world, and we have to think about how to deal with that. Because I really think that times are changing. There are things happening now that are very, very different. Walmart made a deal with the VA last year to do their telemedicine. So Walmart just wants you in their store. That's how they make money. You walk in, you spend money. But they've made really, really nice facilities open to the veterans to do their telehealth visits. Fabulous. It's a win-win. VA wins, Walmart wins. Because guess what? When you come in to do your telehealth visit, guess what else you do? Grocery shopping, clothes shopping, whatever else you need. CVS and Aetna is a very different approach. We'll see what happens. But, CVS picking up Aetna, we can see CVS is trying to bring primary care into the pharmacy world. And then there's always Berkshire Hathaway, Amazon, and JP Chase, which is now called Haven, which is supposed to transform how they can think about that with their employees only. But we'll see what happens because they become a very huge workforce when you actually look at them all combined together. So you have to realize that things are changing. So things that you can't do in your conventional healthcare system, 5 years from now, who knows what you're going to be able to do. So shoot for it, make it work. And think about bridging these ecosystems, because we were talking about this before. We have siloed sciences. But I think the thing that's really important here is we were just talking about, because I said, well, you know, when I first started working over at NSF, they would talk about clinicians all the time. Then I go to a medical meeting, and they'd talk about programmers. And that's not the way we need to look at the world. We have researchers, we have expertise, we have clinical expertise, we have research expertise in mental health. But we also have computing expertise, engineering expertise. They are parallel. They do not overlap very often, but it doesn't mean we don't need to work together. It doesn't mean we don't need to bridge these gaps. And we are equal partners in this. So I think one of the things that happens, my computing folks, literally, I got an email one time from a colleague who is one of the top computer scientists, and she said, do I have to do this? Because it was an NIH review, and I said, yes, you have to do that. They need to know what you know. But when she walked out, she said, I learned so many things, Wendy. It was just so cool. Do you know about clinical trials? Have you ever heard about them? They're really cool. Guess what? There's a world out here that you have no idea of. And there are people that are doing things that you will go, oh my gosh. And you have them all around you. It doesn't matter where you are. There are people everywhere doing this. But I think the thing is, and I also think there's siloed incentives in policy. So I think one of the ways we work together is to show what's effective. How do we think about this? I talked about the Louisiana Public Health Initiative. They're trying to bring together some of the resources in criminal justice, in public health, and in the medical system, because they're seeing people there's a wasteful use of money and resources, because you go here and you get this, and you go there and they take you off that and do something else. It doesn't make any sense. How do we do them together? How do we use them together to make sense? But you all know this is hard. And I've been talking about this, I think, now for years and years and years. But it really is hard to collaborate. It's hard because we have different language. I was in a meeting one day for an NIH center, and I said, so we all agree this center focuses on early stage research, not dissemination. With that, one of the computing researchers jumps up and says, you've ruined my career. You're ruining my student's career. At this point, I know this is coming, so I can deal with it. So I say, tell me what you mean by that. Because I won't be able to do experiments. I won't be able to bring people into the lab to do that. And I said, oh, that's interesting. Can somebody tell me what it means to do dissemination research in health? And they said, oh, that's after trials, after you've tested it. It's the research that gets it out in the community. Computer scientists looked at me and said, oh, who would want to do that? But you know what? We could have done a blowout had I choose to go, well, I don't care, right? But we do this all the time. I remember the first paper I wrote, years and years, with Misha Pavel, when we did the first kind of mHealth meeting. I'm working with a computer scientist who keeps talking about ground truth. And I'm like, look, think, what? Ground truth. What is ground truth? We have gold standards. He says, we're not talking about money, Wendy. So we have language. We have completely different issues. We have completely different questions that we might ask. But that makes us stronger. Because when you look at the world in different ways, I'm telling you, what's been so interesting to me after years of doing smart health is watching how people start to think about the questions differently. So it isn't a question of, can I create the 6-minute walk in technology? It's, why do I need a 6-minute walk, and what data would better suit me to get there? Not, do I need to monitor glucose how often? How can I optimize this? If I need to do sleep work, what sleep information do I really need, and how can I best get this to not burden a patient? And I think it gets to what we all want to do, is to make the systems more effective, more cost efficient, but really deliver the kind of care that we all want people to get. So I think that I'm always talking about bridging these worlds. When I practiced, I would have loved to have had some of the tools that are available today. I look at kind of some of the things that I did and think, wow, if I'd had tools, I could have done things so much better for people instead of saying, you get 6 visits at an hour. So let's spread them out to every other week so you know, you can get the most out of your visits. Can I give you tools that'll help you? I think if you look at some of the work like VA's been doing in their connected health, in their PTSD coach, there's been lots of efforts now. Can you figure out how to get some sensing data? We've actually funded projects that look at online treatment for PTSD using sensors. Can you see what the subjective distress levels are so that you do not push people too far, but you push them just far enough? Also getting data then when they're offline, so you can merge that. Studies looking at natural language processing to figure out how clinician and patients work best together. Are there principles that we can draw out of this? Are there ways to better interact so we understand if your conversation goes one way, will I never see you again? If it goes another way, will I see you again? Will it make a difference? I think this is the stuff we all care about. We all train people for, but it'd be really nice to have the data to get there. I also think there's resources out here. If you work together, this is my idea of like the perfect wicked problem, but resources. I have folks that are on a 9-month salary. They get their salary whether they get grants or not. No, they have all sorts of challenges, all sorts of things, but they're not worried about soft money in the way that most people I know from the health world are. So, right, they can come in. They have students. They have students that are incredible, that are interested and really dynamic, but they also have a problem with diversity. So this is the most women I've seen in a room probably since I started at NSF. It's not a common thing. I can stand in a room where we literally, one of the leaders in computing who's a woman says, there's 2 of us in heels today, 300 people in the room, 2 in heels. That's sad. But the computing community really needs, and most of the engineering community too, really needs a more diverse way of thinking. They need those ideas brought in. These are the kind of problems that people will join your team for. It's not just, can you make more clicks on Google? But instead, can we really think about how do we change the world? How do we really reduce the burden of mental health? How do we provide services to people early and often? You know, I just think about, you know, we talk about smart pens. Could you do this early in school to see if things are going wrong? Some interesting data in the smart pen on Alzheimer's, where they were doing different mazes, and some mazes there was no way to go wrong. And it turned out people with Alzheimer's had much more trouble on a maze that wouldn't go wrong. There was only one way you could do it. They got stuck all over the place. But it's interesting because it leads us to a whole bunch of different questions. But I'm thinking, can we use these tools? Can we use these things to think earlier? Can we use games to help us think about that? What are the questions we should be asking? But it really comes down to what are the partnerships we should do to really increase our impact. So my whole takeaway is there really is this effective. If we're really going to change the world, we need to have these partnerships between some of our fundamental research. We've done it in neuroscience. It seems like the technology, fundamental science and technology needs to come along with that. And basic and applied sciences really need to play together because there's all sorts of ways of thinking and talking and working together that we haven't even found. So this is our listserv. If you're interested, I'll leave the slides. You can have them. Don't worry about it. But thank you. Okay. We have time, right?
Thank you, Wendy, for an excellent keynote. We have a few questions from the audience. There's a couple of people that have asked this, so I'll paraphrase. Hiring an external company to design and beta test is not cheap. Does the NSF partner or fund projects around how industry can work with researchers in developing some of these tools?
say you're almost approaching it the wrong way. Industry has a role in this, but you can partner with your academic colleagues whose students need projects, whose data analytics, whose human-computer interaction, who would love to do these projects, and they can apply for funding. We have many, many programs where people can do it. They actually will get undergraduates to help develop apps. You know, the thing is that it doesn't get you to a commercial product, and you're going to want to work with industry at some point. But starting with industry is going to make it hard. You know, you build your app, then you have to build another app. You have to revise again. It'd be really nice to be able to have the time, work with colleagues in another department and say, how do I do that? Industry will come along, they will be interested, they will want to do all sorts of things, but you'll also have a whole lot better data and a whole lot better information to work with. So I think this is that shared resources I was talking about. There are students, there are funds, there are all sorts of things. And believe me, my world really wants to make a difference. They just don't know quite how to do it out of what industry's done.
Thank you. Do you think there is a need for interdisciplinary collaboration to address issues you brought up regarding usability, smart context, and scalability? I think we know the answer to that. But can you comment a little bit on, with examples on how, just in your experience and in projects you've been involved in, some models for collaboration that have been successful, or if there's any tricks or approaches that people might benefit from knowing or thinking about?
So I think it's find somebody you like to work with, first off. You know, life is too short, so don't find somebody that's annoying and then say, I'll partner with them and bite your lip all the time. But I also think it's really respecting what other people do and what, you know, who brings what to the table. So what I often see is my computing folks will say to me and say, I met this really cool psychiatry researcher. All they want me to do is build an app. That's not what they do. They don't get tenure on building apps. So I said, did you talk to them and ask and say, you know, the things that I'm interested is context-aware or Internet of Things, pulling, you know, data fusion, data analytics, more forms of machine learning. I don't know, should I do that? Yes. But I also think that when somebody comes to you and says, oh, you're clinical. You're clinical, you can help me with this. I want to measure depression, so tell me how. Tell me if this works. You could say, well, what I'm really interested in is this, this, and this. We could embed that into a bigger project. And you will exponentially do better. But I think if you say to somebody, you know, they say to you, I need somebody clinical, and they won't listen to you, then keep walking. That's the wrong partner. You can look at my program at Smart and Connected Health at NSF. There's a whole list of people who would do mental health, who have fundamental computing and engineering projects that address mental health. They're all well-schooled in how do you work across boundaries. But that doesn't mean you have to get one of them. You can go to, actually, so in computing, most of the dissertations are open. You can get on their mailing list and see what kind of information's happening in an engineering program. You can go over and just talk to people when they have an event. Go over and talk. I'm constantly telling the computing community, go to grand rounds, go to colloquium, go to things, and they're like, you should hear them talk. Yeah, you're going to feel the same, and believe me, you'll feel stupid at points, but that's okay because they don't know your world and you don't know theirs. So put the discomfort away and at some level say, I can learn this because you're all really smart or you wouldn't be here. But set yourself up for these opportunities to kind of listen and bump in. And when you hear somebody talking about, so we want to do this context-aware thing and we're going to do in-home this and that and this, you can think, ooh, did you ever think about Alzheimer's in this? How old are the people involved in this? Could we do some screening in here? Could we think about that? And all of a sudden you'll see their eyes light up and go, oh, yeah, my dad has that. I'd love that. So, opportunities. I get excited.
Appropriately so. This next one actually segues beautifully from that. It's a question that's been, well, you can vote on questions on the app, so it's really cool. I can pick the most popular ones. How can we incentivize more clinical awareness and medical education in computer science schools? So I guess they're asking less about collaboration and more about creating awareness at the curriculum or the training level. Do you have any thoughts on that?
So I have very mixed feelings about this. I mean, we're now teaching data science to everybody. So, but I mean, do we really want the computer scientists to have have courses in medicine? Do we really need them to have? I mean, it's really hard. You can do also. I mean, you can go over to your computer science department and say, "I'd like to do a colloquium or tutorial on mental health," and I'm pretty sure students and faculty will show up. But to expect that to be part of the curriculum, I think you all know your curriculum's packed. So is computing, and it's changing all the time. So I'm not sure we can get people. What I see is what happens is when teams partner their students. So you're always going to struggle. If you're partnering with somebody in a different discipline, my experience is building the language, building the culture is hard, and you'll always never be perfect at it, but your students will rock it. Your students will all of a sudden say, "Oh, no, what he means is this. What she means is that." They will totally ace all of this, and they will go on to have another language. So one of the electrical engineers that we've funded, she said every time she would do these projects, she wouldn't understand it, and she said, so finally they got funded, and she said, now my students say to me, no, you've got that wrong. So I think the thing is, doing these teams, we're going to see more and more opportunities for for the students to bring in another language, another opportunity, and they're going to teach their students in a whole different way, too. So osmosis.
Osmosis. I'll read this one verbatim. It has the most votes of any question. With the 1 in 1,000 statistic of patients who enter the healthcare system, how do you view digital therapeutics?
So I think I view this as such an opportunity, because if you think about people that are, if there's reasons why they don't want to come into a system, if they want to use their own doctor, they don't want to just go to it. Like if we think about clinical trials, if you don't want to have to leave your doctor to go into a trial, if you don't want to go places, you can't miss work, you can't do that. How can we think about using digital technology to really transform this? And also for that, I'm also thinking of the idea of distributed trials. Can you continue to go where you used to go? Can you get that technology? But I think digital therapeutics, I mean, we're seeing them happening. I mean, there's all sorts of ideas of how do we do this. You know, from WellDoc, who's I think the most well-known at this thus far for diabetes. But I think we also have a lot of work coming. You know, the virtual reality world is, you know, for PTSD, for exposures, been very, very active. You know, getting people out and getting people doing things, even if it's in a virtual space, is a whole lot better. Everybody's seen people who have anxiety disorders and have been in the house for 3 years. It's a lot easier once you can get people to start interacting in a different way, not avoiding things in a different way. So I think there's opportunities for thinking about this. I also think there's hybrid ideas. I think it was like when I said before, if you get a third of your people are going to use it and do something well, a third are going to do well and then drop off and come back, and a third are not going to use it well at all. Should we be thinking about digital therapeutics for those ones that are going to make it? They're going to work on this. They're going to be able to adjust to this. We can identify them quickly. We can even probably simulate them over time. Who are those people? Who should we be targeting? The ones in the middle, we can figure out what's the best strategy there, but then putting in more of a hybrid approach with the third that won't be connected. So I think there's lots of opportunities, but we haven't tried them yet to figure out what's the fundamental principles driving these.
It's a really interesting point following from that around prescription apps.
Yes.
And the question of whether requiring a prescription for an app might actually preclude its use and restrict access to the app. So what are your thoughts on, you know, where is the boundary between requiring evidence to support the use of an app versus actually requiring a prescription before it can be used. And I think there's a clinical piece to this, and there's a research piece to this. Do you have any thoughts on that?
This is really not my world. So, but I've worked with FDA for years on these projects. I think there's very different models, and how do you think about this? I think there's enough data now that even apps that have good data are hard. It's hard to get them, quote unquote, prescribed, even if the prescription is not electronic, like for a digital prescription. I think one of the things that happens is when you have, when there is a digital prescription where there's a money, there's a fee, there's all sorts of things, it obviously is going to change who uses it and when. But the other thing is it also brings it to awareness. So I remember this in the questions years ago when I used to think open source was the only way to do things, and then the longer I worked, the more I found out open source was one way to do things and maybe not the best. So I think there's different market characteristics that are going to happen. So if you can figure out ways to get your app in front of people and you can get providers to be endorsing it, that's one thing. But I've seen many apps who have good data, and that's not the case. Whereas some of the prescriptions with an FDA approval makes it a very different world.
So you've clearly impressed our audience with your wisdom around these things. So there's some deep questions here. Let's try this one. How do we actually go about breaking out of our respective silos?
Take a risk. So you're here, you've already started the journey, take a risk. Go figure out, go somewhere where people are doing things. So somebody said to me, from one of my colleagues at NIH said, there's nothing new in machine learning, all they're doing is the same thing. And I said, well, where are you seeing your machine learning? And it was at medical conferences. I said, well, here's a couple of machine learning conferences. And she went and she said, oh my God, they were talking about things I had no idea. So you go places that you wouldn't go naturally. Go walk across, it's not across campus either, by the way. Medical schools and engineering and computing departments are usually on completely different campuses, if not even different parts of the state. Nevada has a med school in Reno and another place in Las Vegas, New York, all of these things. So it's not always easy, so you might want to partner in another school or whatever. But getting to know people who will make you feel stupid at first, they will feel stupid around you too, so don't worry. Feeling stupid is growing. It is. I went to my first, in 2009, I went to the Wireless Health Conference when it first started. And I'm sitting there in a tutorial, and a PI that I know well and like is up there drawing one algorithm after another on a board and another. And I'm drooping. I'm like this, and after a while, I'm like this. I got my head on the table by the time we hit the lunch break. There's a man next to me that says, you're not an engineer, are you? I said, no, I'm not, I'm in the wrong place. And he said, no, you're not. Have lunch with me and I'll explain what they're talking about. You just can ignore the algorithms. What they're talking about is good. And so over lunch, he gave me a tutorial of how to think about what they were doing and not get stuck in algorithms I didn't understand. And so I went back and it was like the whole afternoon, it was like, oh, I'm learning. But I think that you have to be open to these experiences, and you're here, so you're definitely open. But I think it's being open, looking for new experiences, looking for things to do that will cross these boundaries. We have actually, in my program, we have an annual principal investigators meeting, and we've actually started inviting people not funded by our program to come, because we found it was a great way for people to get an opportunity and experience to think about things differently. So there's all sorts of things like that you can do. Talk to colleagues that you would have never talked to before.
Thank you. We'll take one last one, and this one, it comes sort of from the industry perspective. So we're asked, integrating with existing electronic health record systems and the current reimbursement models are two strong roadblocks towards tech adoption at scale. What recommendations would you have for someone on the industry side on how to go about overcoming these and building up towards a more broad-scale adoption?
So I think we're seeing, as we move from fee for service, I think we're seeing different reimbursement models coming. This is not my area, but I also think that living and breathing with the electronic health record, I know this is like taboo and I shouldn't say it, but the way we do it now will not be the way we do it in 5 or 10 years. So do not think that, we've gotten to the point where we had nothing. We've gone up to now a huge percentage of the clinics are now have an EHR. Now we can actually build EHRs we want. So I think that then makes opportunities to do different things. So it might be partnering in different ways. We see mental health, often I see them coming in as part of an overall, so it's part of a package of care that people are giving. So, after surgical, they've got somebody they think has a depression problem. Can they build this into the treatment? Because they know if they don't, they're more likely to have a readmission, which is going to cost them. So I don't think that makes it good. You all have a voice, use it. I didn't say that, but use it because I think this is an important issue. But I also think that as we're thinking about payment, it's changing, and the EHR is changing, even though I probably shouldn't say that either, but it is.
Thank you. I think on the topic of taking risks, I had not planned, and neither had you, on doing an Inside the Actors studio format for moderation, but it turned out okay. I don't know how I look on the live stream, so sorry about that. Let's take a break for lunch, and we'll reconvene at 1 o'clock. Thank you, Wendy.
Okay.